Hello, I'm Sandhya Kumar. I'm a general surgeon and assistant professor at the University of California, San Francisco. I have no disclosures to report. In this talk, I will focus on the workup and management of these unexpected findings in the treatment of presumed appendicitis. As you review the literature from 1990s into the 2000s and current time, the rate of negative appendectomy or a finding of normal appendix at laparoscopy has decreased from about 15%. This is largely due to the adaptation of routine CT scanning for patients with right lower quadrant pain, which has a very high sensitivity and specificity for appendicitis, 96%. The most current epidemiological data we have on appendicitis is from the NISQIP database. A recent analysis looked at over 7,000 cases in 2016, and 95% of patients received preoperative imaging, and most of these were CT scans. Based on pathology, the negative appendectomy rate was about 4% overall, 2% for those with positive imaging, and 19% for those without any imaging. Women had twice the odds of having a negative appendectomy and are often found to have ovarian cyst or other gynecologic pathology. An important question is, how good are surgeons at identifying appendicitis based on intraoperative findings? A study from the UK in 2015 compared intraoperative assessment of the appendix by surgeons to the final histopathology. This table shows the data for laparoscopic surgery. In the specimens that surgeons assessed as normal, 27% were actually inflamed on final pathology, and there was disagreement in 14% of the cases, irrespective of the experience level of the surgeon. The study is a compelling argument to remove the appendix whenever appendicitis is a presumed diagnosis in etiology for right lower quadrant pain. In fact, the SAGES guidelines suggest that when a normal appendix is encountered on laparoscopy for right lower quadrant pain, it should generally be removed if there is no other clear explanation for the pain. Many studies have demonstrated the greater level of diagnostic uncertainty of right lower quadrant pain in women due to overlapping signs and symptoms. Additionally, many gynecologic diseases such as endometriosis, ovarian cysts, uterine fibroids, and others can occur simultaneously with appendicitis. The routine use of imaging is helpful, particularly pelvic or transvaginal ultrasound, but uncertainty can still exist even after a complete workup. For example, this CT scan demonstrates a fluid-filled adnexal structure that appears distinct from the cecum, yet ultimately this patient was found to have perforated appendicitis. The most common diagnoses that could be encountered on laparoscopy for appendicitis are pelvic inflammatory disease, endometriosis, ruptured ovarian cyst, and adnexal torsion. Pelvic inflammatory disease can occur with or without a tubo-ovarian abscess and is characterized by salpingitis, as in the top panel. About a third of patients have complicated PID with a tubo-ovarian abscess that can be a walled-off collection involving pelvic organs and can present like appendicitis when right-sided. Most infections are polymicrobial, and initial treatment is with antibiotics. If a TOA is identified when operating for suspected appendicitis, drainage is indicated. If rupture of the fallopian tube or ovary is present, a salpingo-oophorectomy is indicated and should be done by a gynecologic surgeon if available. Endometriosis is generally managed medically, but if encountered intraoperatively and is thought to be an etiology of the pain due to adhesions or obstruction, resection is indicated. Ruptured or hemorrhagic cysts are medically managed if they are small and there's no active hemorrhage. Aspiration or fenestration of the cyst is not recommended. Adnexal torsion, demonstrated in the lower panel, is usually associated with a cyst, mass, or adhesions. Detorsion with ovarian salvage results in return of ovarian function in 90% of cases, and oophorectomy or adnexectomy is reserved for cases of severe compromise, necrosis, peritonitis, or mass. I will briefly discuss other inflammatory conditions. Infectious ileitis often presents similarly to appendicitis and is distinguishable by visible inflammation around the appendix and terminal ileum and mesenteric lymph nodes, with the appendix itself being normal. It can be difficult to distinguish this from actual appendicitis, but most of these infections are bacterial and self-limited. Additionally, an acute exacerbation of Crohn's disease can also present like appendicitis and look similar on imaging. Intraoperative findings include inflammation of the TI and creeping fat. Intervention is reserved for a complicated disease, and initial management is medical. Even in patients that ultimately do get surgery, preoperative optimization improves outcomes. In both of these cases, consider removing the appendix if not involved in the inflammation. This is essentially the recommendation of the management of ileal Crohn's disease from the American Society of Colorectal Surgeons, and that medical management and potential surgery is best approached by a multidisciplinary team. The association between appendiceal neoplasm and appendicitis has been well established, and malignant obstruction is thought to be the etiology of appendicitis in some cases. Large database studies, including NISQIP, estimate that 1% of pathology specimens identify a neoplasm, and that the management of the patient changes in 70% of those cases. The risk of finding cancer on pathology has been shown to increase with age in numerous studies. Additionally, the neoplasm rate is also higher in patients that had an appendiceal mass, either an inflammatory phlegmon or abscess on preoperative imaging. Appendiceal neoplasms are divided into epithelial, about a third, and non-epithelial neoplasms. Epithelial tumors often occur in older patients and can be detected on imaging, but are also often found incidentally on pathology. About 70% are mucinous and 30% are non-mucinous adenocarcinomas. Mucinous tumors are described as low or high-grade appendiceal mucinous neoplasms or mucinous adenocarcinoma based on the level of atypia, differentiation, and invasion. They can have dissemination of mucin and result in pseudomyxoma peritonei. Simple appendectomy is the treatment for adenoma and low-grade appendiceal neoplasm confined to the appendix, and high-grade and adenocarcinoma require right hemicolectomy. Pseudomyxoma peritonei generally requires cytoreductive surgery and or HIPEC and treatment by a specialized center. On this slide is an example of a patient that had a CT done for after a fall and demonstrated a 3-centimeter right lower quadrant mass with possible mucinous ascites. This patient was 83 years old and referred to our HIPEC surgeon. Intraoperatively, she was found to have a perforated appendiceal mucinous tumor, and the pathology was consistent with low-grade mucinous appendiceal neoplasm. She's being considered for cytoreductive surgery with or without HIPEC after prehabilitation. Non-mucinous adenocarcinomas are similar to colonic adenocarcinoma in histology, and treatment is based on size. For tumors greater than 2 centimeters, or those that involve the base and have concerning histologic features, right hemicolectomy and possible systemic therapy are required. Goblet cell carcinomas are intermediate tumors with characteristics of adenocarcinoma as well as neuroendocrine tumor, and can be mucinous or non-mucinous. Localized disease is treated with a right hemicolectomy, and disseminated disease can be treated with chemotherapy or cytoreductive surgery or HIPEC if pseudomyxoma is present. Neuroendocrine tumors are more common in younger patients and more often a truly incidental finding on pathology. Calcifications can mimic an appendicolith on imaging. Patients with symptoms of carcinoid syndrome should get a biochemical workup. Appendectomy can be sufficient for tumors less than 1 centimeter and low-grade features. Tumors greater than 1 centimeter should get a right hemicolectomy. For tumors between 1 to 2 centimeters, the management depends on margins and histology. This schematic provides a management algorithm for appendiceal neoplasms that are recognized intraoperatively. It is important to evaluate the size of the tumor, involvement of the base of the appendix and mesoappendix, and the presence of nodal disease or extraappendiceal mucin. For small tumors less than 2 centimeters without involvement of the base of the appendix or the mesoappendix, appendectomy alone can be adequate. For larger tumors that have involved the base, a right hemicolectomy can be done at the time of the original operation if there's no perforation or mucinous disease. If there is, appendectomy alone is preferred in the acute setting for diagnostic purposes. Tumor markers and staging should be done postoperatively. For neoplasms identified on pathology, treatment similarly depends also on tumor size and histology. For small tumors with low-grade histology, appendectomy is adequate and right hemicolectomy is indicated in larger and more invasive tumors after staging CT and colonoscopy is completed. With peritoneal mucin, patients should be referred to centers that are specialized in cytoreductive surgery and HIPEC. In summary, preoperative imaging has decreased the rate of negative appendectomy. Intraoperatively normal appearing appendixes should be removed in most cases when operating for right lower quadrant pain. Gynecologic diseases can present similarly to appendicitis and should be treated depending on the diagnosis. The initial treatment of inflammatory bowel disease is largely medical. Appendiceal neoplasms can be identified intraoperatively and on pathology. Size, location, and histology dictate the management. Thank you.